Hello everyone. Today we are going to talk about radial artery spasms. So this is a common complications which we face as an intervention cardiologist whenever we do an angiography or any procedure using a radial artery. So many often patients get severe spasm of the radial artery and then we are unable to pass the catheter inside. So what should we do as a resident or an intervention cardiologist so that we can prevent this radial artery spasm? So before that, we should know what is radial artery spasm. It is a temporary sudden narrowing, as you can see here. So normally the radial artery is this thick with this diameter. When it gets spasm, you can see it is getting narrowed. So it will be very difficult to pass any catheter through it. Or if you try to push it or rush it, it may get perforated and can lead to unnecessary complication. So usually whenever the patient gets a severe spasm, the patient will feel that there is a forearm pain or a discomfort during the procedure. Also, there could be resistance to the wire. So whenever trying to pass the wire or sheath or catheter advancement, there will be resistance to that. And when you try to repeatedly manipulate, there will be severe spasm as well. In a rare case scenario, catheter or sheath can get entrapped within the spasm artery and it will be difficult to pull it out as well. So what are the incidents which is reported in various studies that in around 4 to 20% of radial access procedures, you commonly tend to see the incidence of renal, that is radial artery spasms. Also, in some studies, it has found to be about 15%. But moderate to severe spasm has shown that in about 2.7% in some studies and in some trials up to 7% severe spasm has been noted. So who are these patients who are having a high risk of getting these spasms are? First is usually it is seen commonly in female patients because they tend to be more anxious during the procedures. Second, whenever the artery is small. So few people may have a small radial artery and when you try to manipulate that, it can get severely spasm during that. Also, if there is high takeoff of radial artery or if you are doing a multiple puncture, like when we keep puncturing for the radial artery, so with each puncture there will be pain induced and that pain can actually trigger the radial artery spasm to be. Also, using multiple catheters or any pain during cannulation can also lead to that. So best thing in a radial artery, that is radial artery spasm, is always remember that prevention is always better than that cure because cure can be too much intervention. So prevention is always better. So as a resident or a intervention cardiologist, you should remember that always give appropriate sedation. So whenever giving a local anesthesia or any sedation, give proper sedation. So patient should be calm. More calm the patient is, lesser will be the chances of this vasoconstriction or spasm. Try to use ultrasound guided if you are used to it because it may reduce your chances of multiple punctures. So it will reduce that part. So consider pre-puncture nitroglycerin. So you can also give a pre-puncture nitroglycerin, subcutaneous or topical, that can slightly help. But however, it has not been found to be much use, but few people still try that. Other technique is the forearm warming or flow-mediated dilatation, which I'll tell you one by one. So what is the prevention during the procedure is always use the smallest possible sheath. Do not take too much a big sheath. Usually 5 French or 4 French sheath will be sufficient for a angiography. Just for a diagnostic purpose, that should be sufficient. If you are using an intervention part, try to use 6 French. Only in rare case scenario, only use 7 French, but usually 6 French should be okay for most of the procedures, unless and until it involves the left main or a bifurcation stenting like that. Always use a J-type wire. Use the wire you're seeing now. This is called the J-type wire. The wire should be J-type because if it is pointed or straight, it can actually directly touch the wall and can actually trigger spasm as well as the risk of perforation with the straight wire is much high. Give a routine intra-arterial antispasmodic. It is called radial artery cocktail. This cocktail is nothing but consists of two drugs, that is the verapamil. Usually it is around 2.5 to 5 mg. So many of the cath labs may or may not have verapamil, so you can also use dilzem alternate to that, that is around 2.5 to 5 mg. Or you can use nicardipine as well, and NTG is commonly used, which is around 100 to 200 micrograms. So this is what is called as the intra-arterial antispasmodic cocktail, or it is also known as radial cocktail. Okay, so minimize catheter exchange. Always select a proper catheter and use that. If you keep exchanging the catheter, the chances of spasm will be even high. and perform radial angiography early if pain. So suppose there is any resistance, do not try to push, or if there is pain also, always do a radial angiography. Give a small shot with a contrast and check how the radial artery is, whether it is tortuous or is there already spasm, or the caliber of the vessel is too less. So you can already find out with the diagnostic angiography only. So prevention wise, always first thing is always try to be single puncture. Multiple puncture can be risk factors for spasm. Try ultrasound guided. Flow mediated dilatation is nothing but you have to, what you do is in this patient, you have to put inflate a cuff, that is the BP cuff which you use commonly. So normal BP cuff which you would take, you put it in the forearm. So suppose this is the arm you're taking and this is the radial artery. You put a cuff here and you inflate it 30 millimeters of mercury above systolic pressure and keep it for 3 minutes. So what will it do is it will occlude the flow for temporarily for some time. And when you open that, deflate that, all the blood will go there and there will be sudden vasodilation or more perfusion to the radial artery. And thus the chances of spasm will be less, and also you'll be able to puncture the radial artery very easily. Another procedure is called as Balbe maneuver, which is nothing but forearm hitting. That is operator's palm. Usually what the operator do is operator place over the radial artery for 3 minutes. So it keeps it over the palm, over the radial artery, and it gives to the warming of that part. So when you warm, there will be vasodilatation, and thus radial artery can be properly dilated and spasm can be reduced. And always use a hydrophilic coated sheath and smallest sheath size. So, pharmacological measures, where it was seen that various studies, subcutaneous givingly NTG has shown to be of some use. Spasm rate was 1% versus 8% with control, that is with placebo or no NTG. Whereas topical NTG was not found to be much useful in various studies. Even sublingual NTG, there is a limited data whether that will be helpful to reduce the spasm of the radial artery or not. So management of mild to moderate. Suppose there is only mild to moderate, and always remember to stop forceful manipulation. Do not do forceful manipulation. Only if the catheter is passing smoothly, then only you should pass it. Otherwise, you do not pass that. Give additional sedation. Suppose patient only mild spasm, wait for some time. Give some sedation or an analgesia in the form of tramadol or fentanyl so that they can be a little calm. The pain is relieved, and thus it helps in decreasing the spasm as well. You can administer extra vasodilators, like give an extra 100 to 200 micrograms of nitroglycerin or a dilgem around 2.5 to 5 mg of diltiazem. You can try with that as well. Consider cautious radial angiography with diluted contrast. Okay, limit catheter exchange that can actually cause the problem. So this is the cocktail which I have already discussed, that is NTG 100 to 200 micrograms, verapamil 2.5 mg, and heparin. So these three compile to form the standard cocktail actually. So heparin usually we give 50 units, 50 to 70 units per kg body weight, or 5,000 units of heparin is given along with verapamil or nitroglycerin. If verapamil is not available, you can give diltiazem or nicardipine. Or sometimes various catheters gives only nitroglycerin and nothing else as well. In case of severe or refractory radial artery spasm, we always suspect severe spasm when there is intense pain, patient telling severe pain, there is marked resistance, or there is catheter entrapment. What you have to do is you have to escalate with repeat vasodilators, give more sedation, give again vasodilator in the form of NTG or something. Also, you can do is consider balloon assisted tracking. That means whenever you pass the wire, so if there is a sheath is there, you pass a wire through that, and you take a balloon and keep balloon here and inflate it slightly, not to the nominal pressure. Maybe you can, maybe 4 to 5, 6 millimeters of mercury pressures you can inflate to that pressure, and with using that you can pass this wire and then the sheath along with the support of this balloon. This is called as balloon assisted tracking. If refractory, in a very rare case scenario, you can give a region nerve blocked at the axillary nerve, and never forcibly pull an untrapped catheter. Don't pull that because that can actually sometimes tear apart the radial artery and it can be dangerous. So these are the following vasodilators which can be used based on the 2018 American Heart Association statement: verapamil, diltiazem, nicardipine, and with the doses I am giving here, you can go through that. So what is the management algorithm? If there is a radial artery spasm, that is suppose that is puncture induced, like while puncturing only the radial artery has caused spasm during the starting part only. Do forearm heating and flow mediated dilatation with a BP cuff inflated to 30 millimeters of mercury above the systolic pressure for 3 minutes. Or you can give NTG, or always use ultrasound access. Suppose intra-procedure, while you are doing the procedure and following sheath insertion, if it has happened, then you can do is give sedation, or in very high cases, you can give deep sedation in the form of propofol or anesthesia. So these are the options. There are lubricants like Viperglide or Rotaglide may not be available at various centers, but few studies have shown use of this Viperglide or Rotaglide can be useful. You can give sedation with a propofol that can relieve the anxiety and spasm. Regional nerve block, that is ultrasound guided axillary brachial plexus or radial nerve block, can be done. General anesthesia is reserved for very refractory cases only, and various emerging procedures has been developed. Hope you have liked this video. If you have any comments or that, please do comment. I'll try to answer and get back to you as soon as possible. Thank you.